So we will next move to our pediatric portion of the program, which I think is just a fascinating area because, of course, as we treat these children, the risk-benefit ratios are somewhat different. You have young immune systems, young children, years of treatment. You also want to avoid stigma and other experiences that are so important from a formative standpoint and all the march that we've talked about. So Amy Pallard needs very little introduction, but she's the president and founder of the IEC and chair of dermatology and professor of pediatrics at Northwestern. And then Kelly Cordero, who's an associate professor of dermatology at UCSF. So thank you all.
We're going to go as quickly as we can and try to do this jointly. Okay.
And I'll use this.
All right.
Or I can use
So we have a few disclosures. And the first thing that we want to emphasize is that children are not just little adults. They have very different clinical features to start with. Diagnosis with atopic dermatitis is largely clinical and certainly more straightforward than much psoriasis in children. Now, we do see some differences in distribution. In the young child, of course, that diaper area tends to be spared. There's more on the cheek, the chin, and the trunk, and more exudation. And as we see older children and adolescents, we start to see more of that periorbital, perioral, neck flexural, hand and foot involvement, more lichenification, more chronicity. And of course, we know that in either case, environmental influences make a big effect, whether we're talking about saliva or food or friction, but there are maybe inherent differences in the skin at different sites, at different ages, and that remains to be determined.
Now, when it comes to psoriasis, when a patient presents with pink or red plaques with silvery white scale, as in the photos here, it's a very easy diagnosis to make in children. However, psoriasis is often misdiagnosed in kids because of atypical features and distribution. So many children will get scalp involvement, and occasionally, in 5% of cases, just face involvement, or patients may show initially with scalp and face, which can overlap a bit with atopic dermatitis in that regard. Kids less than 2 most frequently present with diaper psoriasis, and this is what distinguishes very young children with psoriasis from atopic dermatitis, which typically spares the diaper area. However, this can be very confusing and confused with other diaper rashes in children, again leading to this misdiagnosis of pediatric psoriasis. Now, when pediatric patients present with gut tape disease, it's a very straightforward diagnosis to make. Fascinating is that the appearance can often overlap with atopic dermatitis. So you can see the patient here, that's Amy's patient, who has features of both psoriasis and eczematous dermatitis. And in fact, in one series, only 9% of kids were correctly diagnosed who had psoriasis because of some of these overlapping features. Children who have a past medical history devoid of atopy or who have a family history of psoriasis are much more likely to hold a diagnosis of psoriasis. And certainly those with early scalp and diaper involvement are clues to a diagnosis of psoriasis versus atopic dermatitis. This is a patient I just saw in clinic last week, and through the slides here, this is to show that yes, psoriasis and atopic dermatitis can coexist. A very interesting story in an adolescent. She has very clear ichthyosis vulgaris and patches of asteatotic eczema, which may not be projecting perfectly. I followed her for years for her ichthyosis vulgaris. In the context of a recent strep pharyngeal infection, she came in with very typical thin plaque psoriasis lesions on her upper thigh, as you can see in the lower photo. So sometimes we'll call this psoriasiform eczema or eczematous psoriasis.
Now, moving on to the epidemiology, we heard already about the increase that we're seeing in atopic dermatitis, and in fact, that's been particularly in industrialized countries and has paralleled the increase in asthma and allergic rhinitis and food allergies. It's thought to be associated with urban exposure, and that has led to hypotheses like the improved hygiene and less exposure to antigenic stimuli as being causative, and perhaps changes in the microbiota which are receiving more attention.
In terms of psoriasis, the U.S. annual incidence, as you heard earlier, has doubled from 1970 to 2000. Excellent work done by Megha Tollefson and colleagues at Mayo showed us, or thought that some of these increases might be related to psychosocial stress in modern society, the obesity epidemic that we're seeing in children, and certainly more two-parent working households, which puts more kids in daycare and perhaps increases kids to infectious triggers.
We already saw this picture showing the disease severity of atopic dermatitis, reminding you that in childhood, actually, a small group is severe, but that percentage increases as these children get older, and especially after 3 years of age.
Now, there are very limited data on disease severity in pediatric psoriasis, and you heard a beautiful exposition of why that might be. Definitions vary, measures for severity in kids aren't really standardized. PASI is typically used in studies, but in the clinical realm, we don't use PASI. There are a few registries that seem to suggest that mild disease is most common in pediatric psoriasis, but this is certainly site, physician, and setting dependent. I looked at my data over a 10-year period, and only 51% of my patients were mild, and 49% were moderate to severe. We need more work in this area.
Now we can move on to ask about the immune pathways, and here again, we don't have very much information in the pediatric population. As you can imagine, it's very difficult to get biopsies, particularly for younger children. But some work that Emma Gutman and I have collaboratively done over the last few years has actually looked at young children under the age of 5 with atopic dermatitis who've had their onset in the previous 6 months, so early AD. And in this case, using quantitative real-time PCR, we've shown strong Th2 skewing in the skin as is seen in adults. And you can see here your red bars representing lesional skin, your pink bars representing non-lesional skin. And as you look across at IL-13 and IL-5 and IL-31, you can see that as in adults, children in their lesional skin have very high levels of these cytokines, but I want to also point out that in non-lesional skin, these are sky high and actually significantly higher than what we see in the non-lesional skin in affected adults.
I'm happy to show you some very preliminary data that my colleague, dermatoimmunologist at UCSF, Mike Rosenblum, and I put together. It took about a year to get 12 children to let us biopsy their skin. It's very difficult to get immunophenotyping done on pediatric psoriasis for obvious reasons. Some of our preliminary data in this study, and these were all confirmed, clinical confirmed psoriasis patients, we found, as you can see in the green bars in the two left lower graphs, a decreased expression of IL-17 positive T cells compared to adult psoriasis, which is in the red graph, and these were significant findings, and an increased expression of IL-22 T cells compared to adult psoriasis in the green versus red bars, which is very fascinating given the commonality of overlap in kids with atopic derm and psoriasis and the strong Th22 pattern in atopic derm. So we need to do more work to try to confirm these findings, but very interesting early data.
Now, if we switch to blood, we can look at the blood phenotype in early pediatric versus adult AD, and here, very interestingly, we see a difference. We see that only the Th2, CLA positive, CD4 positive T cells are increased in the children, and you can see that as well in the adults, but not, as you see here, the CLA negative IL-13 positive, or the IL-22 positive, or the CD8 positive, or the HLA positive, or chronic T cells. All of these are increased in adults, but not seen in the blood of children. Now, I didn't show you, but there is an increase in the skin of early childhood AD of your IL-22 as well, but none of these are seen in the blood. Now, there is a marked reduction in blood of the interferon gamma, CLA positive. Again, CLA positive are your skin homing cells, CD4 positive cells in children. And as you can see circled in red, we only see that in the most severe adult patients with atopic dermatitis. Now, hot off the press, I'm going to show you in just a minute some proteomic data, but let me just tell you that older children are now being investigated for these possibilities, because I think one of the important things to recognize is this difference in the blood may present to us a window of opportunity. And just as you just heard from Thomas Bieber, his dream, well, we share that dream, because maybe this is telling us even more so that there is this window during which time, if we jump in and treat more aggressively to suppress the Th22 axis, we may be able to prevent the development of other forms of atopy. And by looking at older children and filling in that spectrum, we may be able to address that more fully. Now, I've been talking here about in skin, the mRNA expression in blood flow studies. I want to just give you a little clue that proteomic assessment tells us there is indeed increased Th2 in the blood in terms of protein. And Patrick Bruner will be presenting this at the IEC Symposium at the SID. I want to encourage all of you to come to that on Friday at noon there to hear some of this data. I also want to mention Th17 briefly because he's also found that in the blood. And this is a difference that I'll show you in a minute when we talk a little bit about infection. But children in general have higher levels in their skin of Th17 pathway, and this is certainly seen in the children of atopic dermatitis. And here you can see, as opposed to adults with atopic dermatitis who may show evidence of other markers in their blood, Th17 is not increased in adults, but here it is in children, and that's another difference that we need to keep in mind. Now, when we move on to comorbidities, in atopic dermatitis, of course, we know all about the atopic disorders, and again, we may be getting some clues from our immunophenotyping studies that tell us more about this in the future. We also know about the infections, the high risk of Staph aureus and more disseminated herpes and molluscum, as well as infections at other sites, perhaps. I just wanted to show you another bit of data looking at cathelicidin in the skin of children at this early period of time, and emphasize that this long-held concept of adults not being able to mount this antimicrobial peptide response, again, shown here. But if you look at the children at the left of the slide, you can see that indeed they mount a response, and this again tells you about this Th17 axis in children. Healthy children, much more of a response as well, but we see an increase in children with atopic dermatitis, and not that suppression that we see in adults with atopic dermatitis as opposed to psoriasis. So this needs more research, but it suggests that early on children have a much brisker antimicrobial response. We'll also talk in a minute about neuropsychiatric disorders.
Let's look at the comorbidities of pediatric patients with psoriasis. We've enjoyed having some data to actually review and discuss for years. We were reading all about adult psoriatic patients, and now data are emerging at a rapid pace. Psoriatic arthritis was one of the first first recognized comorbidities of pediatric psoriasis, and certainly kids do get psoriatic arthritis. It's at a much slower and lower rate than it is in adults, and we seem to have a greater rate in the United States than is observed in Europe. Let's look a little closer at obesity. So, studies showing an association with obesity and pediatric psoriasis absolutely span the globe. From the very first study as part of the etanercept double-blind trial back in 2008, in that cohort of patients with moderate to severe disease, 37% were found to have obesity. In Italy in 2009, almost 50% of patients with a spectrum anywhere from mild to severe psoriasis were overweight versus 27% of controls. In Germany in 2010 and more recently in 2015, we've seen several-fold increases in components of the metabolic syndrome in addition to obesity. A large Kaiser Permanente database in Southern California found overweight and obesity increased the odds of psoriasis in that group, and that independent of body mass index, there was an increase in lipids in that pediatric group, and that psoriasis was much more severe in the patients who were more obese. In China, we're seeing the same. 25% of patients were overweight or obese versus 12% of controls. And again, looking at my own unpublished data as a comparator reference, in my moderate to severe patient population, psoriasis was much more severe in the obese patients. The most important study that's really been published, though, in the last decade has been this international study that was published in 2013. Amy was the lead investigator. This was a global study that involved 409 patients from 9 countries. And in summary, this study showed that globally, the odds of obesity and increased waist circumference were higher in all psoriasis patients. And the more severe the psoriasis, the more obese the patients were, including central adiposity, which puts a patient at increased risk for metabolic and cardiovascular disease. And this was a really important study because measures of adiposity included not just body mass index, which is most common, but also waist circumference and waist to height ratio, which are surrogates for visceral adiposity and may be more sensitive indicators of metabolic disease and cardiovascular risks in kids than is BMI. And so in summary of the aggregate data, adiposity is increased among pediatric psoriasis patients. The obesity association in kids has been found to be strong, global. It's most pronounced, however, in the United States, particularly that central obesity. And the risk of obesity is proportional to the severity of psoriasis. A really interesting sub-analysis from the international study published by Becker et al. In JAMA Derm showed that high adiposity, either kids that were overweight or obese, for whom growth chart records were available from their pediatricians, showed that high adiposity preceded the psoriasis by up to 2 years and 93%. And this really underscores a role for early intervention. And so there's been a lot of talk about marches this morning. So cardiovascular, is there a psoriatic march in kids? So we've talked about the association with obesity, components of the metabolic syndrome. Even abnormal lipid function has been recently identified in pediatric patients. And so the question really is can chronic systemic low-grade inflammation in childhood result in cardiovascular disease in early adulthood that Joel and others have identified? And what is the relative contribution from obesity versus inflammation? And will reducing psoriasis severity and weight or both reduce the risk? And my dream is that we have sensitive biomarkers at some point to identify those children at greatest risk.
I'll just say a word about the possibility of metabolic disease in atopic dermatitis children and doing a comparison here, and there's certainly been some evidence presented in adults. And in fact, Jonathan Silverberg's work doing a meta-analysis of 30 studies that included both adults and children, so it showed an increased odds of overweight and or obesity in North America and Asia, but interestingly not in Europe. In addition, a caregiver report of weight and height from the National Survey of Children's Health has shown an increased odds of obesity overall and in moderate to severe atopic dermatitis. And case control of doctor-diagnosed moderate to severe atopic dermatitis has shown an increased odds ratio for obesity, a higher waist circumference, and increased systolic blood pressure. So you may ask, well, gosh, we've seen many children with psoriasis who clearly are overweight or obese, but we don't really think about that much with atopic dermatitis. And that was certainly a question I had. And possibly that relates to the fact that when we're looking at the absolute BMI percentile, it's much higher in psoriasis versus atopic dermatitis. So we just really may not be noticing it in our population. And I will add that there is now data showing more sedentary behavior, more TV time, more video games in children with atopic dermatitis, and this may be exacerbating their cardiovascular risk. Now, moving on to quality of life and neuropsychiatric comorbidities, it's well known that both children with psoriasis and atopic dermatitis have a poorer quality of life than even children with epilepsy or enuresis or diabetes. And with atopic dermatitis in particular, we think about some neuropsychiatric issues that have been shown to be increased. These include depression, anxiety, conduct disorder, and autism, but perhaps the greatest attention has been paid to the increased risk of attention deficit hyperactivity disorder. And this has been shown to have the strongest association if more severe atopic dermatitis and poor sleep, and usually this association is with the earlier onset atopic dermatitis, and that's been associated with a medication requirement to combat attention deficit disorder.
Similarly, psoriasis has been associated with increased depression scores, anxiety. These children have social isolation. There's also an association with bipolar disease. And importantly, it's talking to John Koo at my institution, who's a psychiatrist and a psoriasis expert, the inflammatory profile in psoriasis is very similar to the inflammatory profile in the brain of patients who have organic depression. So very interesting parallels and not just a downstream effect of psoriasis. Importantly is quality of life. Alexa and others have done incredible work showing impact on quality of life of patients, but Mega Tollefson and her group at Mayo just published a beautiful paper talking about the quality of life in caregivers of psoriasis and how significantly impacted caregivers' life is in multiple domains.
So therapy, our final domain here, and there are shared pediatric responses to topical therapies. We think about nonspecific, anti-inflammatory, topical steroids, and certainly we use that for both, although more potent steroids are required for treating psoriasis versus atopic dermatitis. We can think about calcineurin inhibitors. We use those extensively in children on the face, but they don't work that well for psoriasis on non-facial areas, but can for atopic dermatitis. We've used tar and anthralin, things like that, and they can be effective for both disorders. Salicylic acid we use for lichenification in atopic dermatitis and seems to be tolerated well. We can think about PDE4 inhibitors, crisaborole for atopic dermatitis. Could that be effective for psoriasis? Well, there have been some studies. That remains to be seen. But we do know that there are some differences. For example, we can use retinoids. We can use vitamin D3 in psoriasis, but they would be very poorly tolerated for atopic dermatitis. Now, when we think about the question of what are we most commonly using as far as systemic agents for atopic dermatitis, we have the TREAT survey initially performed in Europe and then in the United States. And when we look at the TREAT survey in Europe, we see that the first-line choices are primarily cyclosporin, but followed by oral steroids and then azathioprine. In the TREAT survey in the United States and Canada, we again see cyclosporin in the lead as first-line agent, at least to start with, but then methotrexate and mycophenolate mofetil as the other choices in the United States. In both of these surveys, the concerns, side effect profiles, and the perceived risk of long-term toxicity. And I can't emphasize enough how many children who probably could benefit greatly from systemic intervention have not been treated because of these fears about side effect risk. Now, that means that the experience in children has largely been based on case series and anecdotal use. There have not been large placebo-controlled or comparative trials of any of these agents for atopic dermatitis, and there are no data yet on any targeted biologics in children.
Now, what about pediatric psoriasis? So our research investigator, psoriasis investigator group, did a survey very almost exactly like the TREAT study for atopic dermatitis, and it's called CAP, as you can see here. And among all of the results, I wanted to share with you the first-line choice as selected by respondents to the survey for moderate to severe psoriasis. 60% listed that phototherapy would be their first-line choice. 35% listed systemic therapy in the order that you see here, methotrexate, much greater than cyclosporin, much greater than oral retinoids. And then biologic therapy was cited by only 5% of respondents as being a first-line choice for moderate to severe psoriasis. And interestingly, the exact same reservations were cited as a concern about using systemic therapy, which was that the side effect profiles and perceived risks of long-term toxicity are great. Now, there's overlap in systemic therapy for atopic derm and psoriasis, and those drugs here that have an asterisk beside them are used for both. which leaves us with very few others that are only listed for used for psoriasis. Now, we do have one randomized double-blind placebo-controlled trial, thanks to Amy and the etanercept study, and now finally, my birthday was in November, but my biggest birthday present was when etanercept got FDA approved by the FDA on November 6th, which was fabulous because prior to that we had nothing for pediatric psoriasis that was on label. Thanks to many of you in this room, the IEC, the IPC, and other people who have advocated, pediatric patients are now involved much earlier in systemic therapy trials. You want to summarize this, or I'm happy to?
Go ahead.
Okay. This is a study, really, again, that was spearheaded by Amy in this country and Inga Bronkers outside of the U.S., which was a really nice international retrospective chart review of what are we doing, what are pediatric dermatologists doing for pediatric psoriasis. There were 10 U.S. sites, 10 European sites, almost 450 children were included. Phototherapy was used in 19% of those patients, and as the only agent ever used in 13%. And here's the systemic breakdown. So, and of the remaining 390 children that used a systemic therapy, methotrexate was the most common, used in almost 70% of patients. And biologics were a very distant second, but of all of the biologics, etanercept was the most commonly prescribed, and others such as retinoids, fumaric acid in Europe were also used. Let's see. I want to just tell you an interesting folic acid story that came from this study, that the scheduling of folic acid has something to do with the GI adverse effects of methotrexate. So in North America, we primarily dosed folic acid 6 or 7 times a week, which actually resulted in fewer GI adverse events than weekly dosing, which is the primary European schedule, regardless of the total weekly dose of methotrexate. Of folic acid and methotrexate, actually. Other results that were interesting to note here is that there was a much higher risk of having at least one drug-related adverse event, GI adverse event or labs with methotrexate versus the TNF inhibitors. But there was actually a lower risk of documented infections in the methotrexate group versus the TNF group, but these were mild, insignificant infections that did not necessitate treatment discontinuation. The most common adverse event with TNF inhibitors, as could be expected, was injection site reaction, and importantly, no patients in any subgroup developed TB or malignancy. Oops. I'll quickly just mention that TNF inhibitors have the most data for pediatric psoriasis. The randomized controlled trial and a 5-year open label extension of that showed the efficacy and safety of etanercept with really only one serious infection and no malignancy or deaths. It's recently been showed that standard dose adalimumab is superior to low dose methotrexate with comparable adverse events. And some of the newer biologic therapies, we really don't have a lot of data for pediatric patients. However, I mentioned here ustekinumab that has shown some early success for atopic derm, as you heard about earlier. And finally, these are the drug approvals that are available or that are in the United States and Europe. So Enbrel was approved in 2009 in Europe for age 8 and above, which has now been reduced to age 6 and above. We have it now in the United States approved for patients aged 4 and above. Humira and ustekinumab both approved in Europe in 2015 for age 4 and 12 respectively. And most importantly, which is really good as a pediatric dermatologist to recognize that ongoing, or for anybody that takes care of kids, that we have kids in trials now. So there's ongoing studies in the US of the PDE4 inhibitor apremilast for patients age 6 and above, and upcoming ustekinumab and ixekizumab trials as well.
So anticipation for the future with respect to therapy, the need is great, no doubt, for both topical and systemic options for children with psoriasis and atopic dermatitis. But ideally, we want therapeutics that are pathogenesis-based. And that's going to require a better understanding of the pathogenesis and the course of pediatric psoriasis and atopic dermatitis in children of different ages and how that compares to adults. Several medications may be effective for both diseases based on some shared pathogenesis and mechanism of suppression of inflammation. Maybe some of the PDE4 inhibitors, the JAK inhibitors that are coming up. But that immunomodulators targeting Th2 pathway activation show promise for adult AD, and our phenotyping in children would suggest at all ages, possibly in preventing the atopic march. And targeted modulators towards the Th17-IL23 pathway activation are moving towards pediatric use for psoriasis, and we'll have to see if there's going to be any benefit as well in atopic dermatitis when we think about the role of IL-22 antagonist therapy in pediatric psoriasis. I think given what we just heard a little inkling of from Emma today, we need to think about this as well for atopic dermatitis. And Kelly and I can't stress enough the need for a prospective registry for children. Incredibly great if it could be a shared database among all these systemic medications, and maybe even something to look at atopic dermatitis and psoriasis together. So that's one of our dreams for the future. And with that, thank you for your attention.